is Irwin Goldstein. I'm a sexual medicine provider in San Diego, California. Lots of things. Dermatologic conditions, inflammatory infectious conditions, hormonal conditions, pelvic floor, high tone conditions, neuroproliferative conditions, neurologic conditions. Then get into psychologic conditions. Pretty much everything. It's an epidemic, sexual pain disorders in women, and in general, it's 30 times more prevalent in women than men. About 1 to 3% of men will say they've had sexual discomfort, pain in the last 2 months, and it's 30 to 40% of women. It's crazy. In general, the providers of women's health care aren't really interested in this stuff. They don't want to examine, they don't want to learn. So women with this problem have journeys till they get care. I love when people ask me questions as to what treatments. The treatment is based on the diagnosis. It's like other forms of medicine. I'll just give you my honest frustration. When people say, here's a treatment, that's nonsense. If I walked into an emergency room with chest pain, I wouldn't expect an aspirin. I'd expect a freaking diagnosis so that I could get the correct treatment. This is the sad part is providers don't know how and what to look for to get the correct diagnosis and then to get the correct treatment. So the answer to your question is multifaceted, it's multidisciplinary, but really depends on the trigger for the pain. Women should talk to their doctors if they have a knee pain and not be embarrassed. Women should talk to doctors about ankle pain and not be embarrassed. Women should talk to their doctors about headaches and not be embarrassed. What the F is the difference between any of these and having a woman's sexual pain? It's just another body part and it hurts you. It interferes with your life quality, interferes with your special intimacy time. Go out there and get care. Go push the envelope. This is not something you need to be embarrassed of. It's something you need to care for. Well, pretty much everybody in menopause has what's called GSM. And GSM is genitourinary syndrome of menopause. The nightmare of menopause is that the ovary, the factory of hormones that starts sort of at age 12 and then sort of at age 52, ends, 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 it's over, it's nada, there's nothing going on. So tissues that have received hormonal support for 40 years gets zero support. So there's atrophy and all types of changes. It's so sad. And the appreciation of menopause by the providers and the patient is so limited, it's so scary. And it's so easy to manage and treat this. And God bless the American Urological Association for being really the first major provider organization, international, to put forth guidelines. And Dr. Rubin and I were on the guidelines, and it was totally fascinating to be involved in the generation of those things. It should be a priority topic. It should be that partners are aware that it's 30 times more common. It should be aware to families and to parents to ask the question rather than to assume everything is perfect. But it is not that way. But there are specialists. I'll consider myself one of a handful of specialists that do this over and over. And the detective work involved is fascinating because people have multiple reasons for having pain. And you've got to figure out what are the reasons before you treat. So, we have people with problems with clitoral adhesions, but in conjunction, their motocycle bike rider, people who have penile nerve, in conjunction with back pain and sciatica, who have cauda pathology like a herniated disc, who in conjunction with have depression, anxiety, OCD, mental health challenges to deal with all this stuff. And past history of trauma and abuse that would throw that into the mix. So management of them is just so cool, because once we figure out the reasons, we can now attack each one of them. I'm just giving you a bad example, but we see many like that. Yeah, it's the sex detective aspect of women's sexual pain is fascinating from the provider's point of view. Let's go into the latter, hormones. They're amazingly effective, and when monitored properly, are safe and effective. Lasers and PRP are a tiny bit scabby and a little bit not scientifically or evidence-based. They sound glitzy, but not evidence-based. If you have sexual pain, find a professional who loves this area, who will spend time, who will show you your anatomy on a huge plasma TV so you can watch what we're doing when we're doing the examination. Who will take the time and effort and spend literally an hour or so doing the examination. Who will work with you over time to develop a therapeutic plan. That's what you need.